Clinton with the Heart of Medicine, and today is Sunday, May 18th, 2025. So this video is just about some clinical pearls for the internal medicine board examination. So this can help anyone who is preparing for the board exams or who's studying for Step 2 CK internal medicine section of it, or wants to know a little bit more of internal medicine. So I'm just gonna share with you some pearls I learned from some questions I took today. So let's just go through it. So this video is helpful for anyone who wants to stay active while they wash dishes, walk the dogs, etc. So okay, let's see which pearls I can pass on to you guys. So first pearl will be lung protective ventilation. So it's interesting because when you think about intubating a patient in general, you would think, okay, why am I intubating this patient? Is this because the patient has ARDS, so acute respiratory distress syndrome, or is this anything else, basically? Why did you have to make this distinction in the past? It was because if the patient had ARDS, you wanted to do the lung protective ventilation. What did that mean? Well, it basically meant a low tidal volume, so a tidal volume more along the line of 4 to 6 mLs per kilogram of ideal body weight, versus going up to 7 to 8 milliliters per kilogram of ideal body weight. So one was that. So you wanted to have low tidal volumes. You wanted to potentially have a little bit of permissive hypercapnia. So the pearl here is that I was answering a question and this patient didn't have ARDS, and they're asking me what should I do because the patient has metabolic alkalosis. The patient was recently intubated. The pH is 7.51. The PaO2 is 72. The PaCO2 is pretty depressed, so it is 24. So there you can note that there's a very clear respiratory alkalosis. And they're asking you, what do you want to do? What's the next step in management? So options are decrease respiratory rate, decrease tidal volume, increase depth of sedation, increase positive and expiratory pressure, or increase the respiratory rate. So right off the bat, I knew, yeah, increased respiratory rate is not an option here because we want to actually reduce ventilation so that the CO2 isn't so low and the patient is not so alkalotic. So basically here what we have is that I was between decreasing tidal volume, which made a little bit of sense, decreasing respiratory rate also made sense, and increasing depth of sedation. All those make sense because this patient had a set respiratory rate of 16 and the patient was breathing at 22 times per minute. So I thought, okay, so we can sedate the patient a little more so they don't breathe over the vent. But actually the right answer here was decreased tidal volume. So there's a succession of events, and usually the first thing you want to do is, in any patient that you intubate nowadays, is lung protective ventilation. Always start off with the lung protective ventilation. Seems like this is a little bit of new information, and from there you can adjust as necessary. So you start off with what is the initial ventilation settings: an FiO2 of 100%, a PEEP of 5, ventilation you want tidal volume nearing 6 ml per kg per ideal body weight, and respiratory rate between 14 and 18. After 10 minutes of ventilating the patient, you should know how the ABG is being altered by these settings. So you're going to get an ABG by 10 minutes. Not as soon as you intubate because it won't tell you much. 10 minutes after intubation, you get the ABG. Now you're going to assess two things. One is going to be oxygenation on one side and the other one is going to be ventilation. So how do you assess oxygenation? It's going to be the PaO2. And how can you alter oxygenation? You can alter it by changing the FiO2 or changing the PEEP. How can you adjust ventilation? So ventilation, well, first of all, how do you assess ventilation? You will assess it with a PaCO2 and the patient's pH, okay? And how do you adjust ventilation? With respiratory rate and tidal volume. So that's basically what you're going to do. And in order to ensure lung protective ventilation, you will evaluate lung compliance, meaning that you will measure the P-plat or the plateau pressure, which is usually done on inspiratory hold. And of course, the goal will be less than or equal to 30 centimeters of water. And you will adjust as necessary. Okay, so that was the learning objective for that patient. And that's the clinical pearl. Next thing we can talk about is, the succession of events if you have respiratory alkalosis. First, lower tidal volume. Secondly, decreased respiratory rate. And lastly, increased sedation as last resort. Okay, next question. Okay, this next question was an interesting question because it takes us to biostatistics. And it's telling us that a patient has a relative risk of 2.28 compared to placebo. So it's showing us also a confidence interval of 95%, saying that the interval goes between 1.32 and 3.96. So basically the question is asking which of the following best represents represents the best interpretation of the 95% confidence interval. So this question is just asking us, what is a 95% confidence interval? What does it mean? So there are several options. I'll read them to you. Option A is about 95% of patients in the treatment group had a risk between 1.32 and 3.96. Option B is if the study were repeated 100 times, the confidence interval would be 1.32 to 3.96 in 95% of cases. And there's several other options similar. I'll read another one. If the study were repeated 100 times, the relative risk would be between 1.32 and 3.96 in 95% of cases. So the main thing I want you to memorize here is what the confidence interval of 95% means. And it basically just means that if a study were repeated 100 times, the results would fall within the range, within that range in 95% of cases. That's all it means. So I'll read this one because I know biostatistics is usually sort of it's like a tender spot for most of us, right? So in general, 95% confidence interval means that if the study were repeated 100 times, the result obtained would be within that confidence interval range in 95% of cases. It does not mean that the same result or the same confidence interval would be obtained in 95% of cases, or that 95% of patients in one group fall within that exact range. A confidence interval that does not cross the null value, or a relative risk of 1 in this case, reflects statistical significance. Okay, so it's interesting, right? Because when I try to make sense of it, it's tough to understand why this is the right answer. So because I was between two options. I was between the correct option. I'll repeat it again so we can hammer this point in your brain. If the study were repeated 100 times, the relative risk would be between whatever numbers are the confidence interval, right? In this case, 1.32 and 3.96 in 95% of cases. What I marked initially was about 95% of patients in the treatment group had a risk between 1.32 and 3.96. So that's not the right answer. That's not the right answer. So confidence interval should read always starting off, if the study were repeated 100 times, blah, blah, blah. The relative risk would be between such and such. So yeah, if you can explain this a little better, I would appreciate maybe in the comment section below, explain this so we can learn it a little better. But yeah, for this one, maybe a little bit of memorizing. So next question. This other question is a patient that they're asking us. The patient has an x-ray that they're showing you that the patient has acute pain in one of the knees. They show us the x-ray of the knee, and between where you should see just radiolucid, or where you should see dark, meaning where the cartilage should be, between the femur and the tibia, there's actually, on both sides, there's a little bit of whitish color, a whitish hue. So that's important for you to always pick up. Remember, nothing in these tests is by chance. If it's there, it means something. So that whitish thing, or radiopaque thing, where it should be dark, is chondrocalcinosis. So, oh wait, I'm talking about another question which is pretty similar, but let's maintain that same idea. Okay, yeah. So that's chondrocalcinosis. Okay, so we have that. What else was done? A gram stain or synovial fluid was taken, and it revealed 20,600 leukocytes with 90% neutrophils. Gram stain is negative and no crystals were visualized. The synovial fluid culture and was taken, and repeat blood cultures as well. The patient was clinically doing well, and they're asking us what is the most likely cause for this patient's knee pain. So we have different options, and I was between two options because I was like, okay, one option was crystal-associated arthritis, and everything points based on all I have told you. It sounds nice to mark crystal-associated arthritis, but when I saw that no crystals were present, visualized, on synovial fluid, I was like, no, I'm not marking that one because probably it's something else. But actually, the sensitivity of finding crystals in the synovial fluid, even if in a patient with crystal-associated arthritis, is not that high. So not finding crystals is not going to rule out your diagnosis. If you have several clues pointing towards it, it can still be the crystals, right? So what are you expecting to find in the joint fluid of crystal-associated arthropathy? It's going to look translucent or opaque. The white blood cell count is usually going to be it's a broad range between 2,000 and 100,000 per millimeter cubed. And polymorphonuclears or neutrophil count will often be above 50%. So as you see, I'm not mentioning anything about the crystals. They are not necessarily going to be found. Okay, so educational objective says acute crystal arthritis, such as gout or pseudogout, often occurs in patients hospitalized with acute illness. So this patient had pneumonia and had been started on antibiotics 3 days ago, and then started with the pain in the knee and the effusion. So the clinical arthritis. The diagnosis of pseudogout is suggested by chondrocalcinosis on X-ray and synovial fluid showing rhomboid-shaped, positively birefringent crystals under polarized light microscopy. But well, you not always will see the crystals, right? As I mentioned. So let's see what else it says here. Let's see what else it says. Yeah, CPPD, right? So that's calcium pyrophosphate dihydrate deposition disease, or pseudogout. The crystals are small and often scarce, meaning they may not be present. And crystal microscopy alone has low sensitivity. Okay, so that's basically the learning point from this question. Now let's move on to the next one. This other question was interesting because they were showing us a patient with CKD, and they're asking us how can we reduce the progression of CKD in this patient, and they give us different options. So this is the interesting part. They tell us the patient just has CKD. They don't tell us specifically which type of CKD the patient has. They don't give us a biopsy of the kidney to specify the type of CKD. They just say the patient has CKD. They tell us the patient is obese, BMI is 35. They give us the patient's some labs for the patient, including a lipid profile and including some labs. So phosphorus is 5.1, so it is elevated. Hemoglobin is 11.2, albumin 3.6. There is proteinuria. 24-hour urine protein is 560 milligrams. Remember that significant is about 300 milligrams. Urinary sediment shows hyaline casts. Total cholesterol is 200, and LDL is 112. So the question here is, which most likely will reduce the progression of the renal disease? Option A, dapagliflozin. Option B, epoetin alpha. Option C, phosphate restricted diet. Option D, rosuvastatin. Option E, weight loss. So when I see this question immediately, as soon as I see the options, whenever you see SGLT2 in the option list, it's going to be one of your top contenders to be the correct answer, because SGLT2s have so many benefits, and they're being shown to have so many cardiovascular benefits, and in the realm of heart failure, in the realm of diabetes and CKD and all that. So I did remember, oh, SGLT2 is associated with a reduced progression of CKD. So I'm like, okay, I'm going to mark this one. And then I see an option lower down, and I'm like, there's some interesting options here. So the only one I crossed out immediately is epoetin alpha. I'm like, no, this doesn't make sense. But for example, phosphate restricted diet in a patient with a high phosphate, that made a little bit of sense. I'm like, okay, might make sense, but don't feel strongly about it. Rosuvastatin might make a little bit of sense, but weight loss. So when isn't weight loss the right answer? So that's another option that whenever it's in your option list, it's going to be a very high contender for being the correct answer. So I was between those two options, between dapagliflozin and weight loss. So what did I mark in the end? I marked weight loss. 40% of people marked weight loss, and that was incorrect. The answer was dapagliflozin, where 46% of the people marked it correctly. Why is this the case? It is the case because dapagliflozin, as an SGLT2 inhibitor, slows progression of renal disease regardless of cause in both diabetic and non-diabetic patients with proteinuric chronic kidney disease. Why wasn't it weight loss? Weight loss should be recommended to all patients with obesity, but it has not been shown to slow progression for most etiologies of CKD. A notable exception is obesity-related focal segmental glomerulosclerosis. However, FSGS was not seen in this patient's renal biopsy. So that's a good pearl. And let's speak about phosphate and statins. So phosphate says a phosphate-restricted diet is recommended for patients with CKD as part of treatment for secondary hyperparathyroidism, but has not been shown to slow CKD progression. Option D, high-intensity statins are commonly used in patients with CKD to help reduce cardiovascular risk, but statins have not been clearly shown to reduce CKD progression. So those are the main incorrect questions I got. We're going to see a couple other questions, the ones I got correct, just to get the clinical pearls for everyone's benefit. So this patient, they show me a 40-year-old female who had a baby, uncomplicated cesarean delivery 48 hours ago. Patient was fine. The pregnancy was fine. The patient didn't have any complications during the pregnancy. This cesarean delivery was for breech presentation. And they're showing us that now the patient, 48 hours after, has several things. Has a blood pressure of 196/112. Pulse is 120. Pulse oximetry is 86% on room air. The patient has bilateral diffuse alveolar infiltrates. EKG shows sinus tachycardia and upsloping ST segment depressions in inferior lateral leads. And they're giving us some labs here, basically showing similar things. They're showing us a little bit of anemia. They're showing no acute kidney injury. And a urinalysis, which is showing protein, 3+ protein, and the rest of it is normal. So the question is, which of the following is the most likely diagnosis in this patient? So I'm just going to mention the most difficult options to choose from. So I'll mention amniotic fluid embolism. That's one option. Another option is peripartum cardiomyopathy. And another option is preeclampsia. So most people got this question incorrect. Most people marked amniotic fluid embolism. That was incorrect. I was with the winning group in this one. 34% of us got it correct, which was preeclampsia. And to be honest, I didn't spend too much time in this question. Why? Because I saw that the patient was pregnant, just had a baby 2 days ago, has proteinuria, has high blood pressure. It's very difficult that the answer is not preeclampsia in the setting of them giving you this information, right? So it was an extremely strong contender. I was also thinking, could this be amniotic fluid embolism? Maybe, but if they put preeclampsia there, it's very difficult to go against it. Remember that the trick here, or the pearl, is that preeclampsia occurs after week 20 of pregnancy, and it can also occur after pregnancy, and the date or the time in after pregnancy would be up to how many weeks? I think it's maybe 5 weeks. Let's see how many weeks post-pregnancy. Pulmonary edema. 6 weeks postpartum. So preeclampsia is defined as new onset hypertension and proteinuria, can present from 20-week gestation to 6 weeks postpartum, and can be complicated by pulmonary edema. Treatment includes blood pressure control and seizure prophylaxis, i.e. magnesium sulfate. So the other thing, why wasn't it amniotic fluid embolism? Because although it can cause acute dyspnea, the majority of patients have hypotension, such as cardiogenic shock, and disseminated intravascular coagulation. So you would have seen bleeding, bruising, all that, and labs consistent with it. So next question, Pearl, is we have another patient, a 23-year-old male. He has some history of weight loss and poor energy. This has been going on for a while. It's been going on for 6 months now. So yeah, it's sort of chronic. So has some vague abdominal discomfort, some soft stools, and chronic back pain. Okay, all that is interesting. Is a smoker. And he's had several sexual partners over the past 3 years and does not use condoms consistently. Was found to have HIV with a CD4 count of 650. And physical examination showed scattered bronchi over the right upper lobe, the abdomen mildly tender in the epigastrium, and no hepatomegaly. Okay, they gave us some labs. Serum chemistry, nothing is abnormal. Liver function tests are basically just a very trivial elevation of, no, not even elevation, just trivial elevation of ALT, very minimal. Nothing is special there. So the question, but this is the thing. CT scan of the chest and abdomen demonstrates right upper lobe bronchiectasis with some surrounding fibrotic changes and pancreatic calcifications with atrophy. So the question is, which of the following most likely to establish the diagnosis in this patient? I'll just tell you the toughest to choose from. So one option was, well, I'll tell you all. A is bone marrow biopsy. B is immediate skin test reactivity to aspergillus antigen. C is serum immunoglobulin quantification. D is sputum smears with acid-fast staining. And option E is sweat chloride test. So this question most people got correct. Usually I start with every question looking at the options. So I just read the question and see the options. And sometimes I'm able to cross out things without even reading the other things. For example, if I read something that doesn't make any sense, like that I know that will never be an answer. So for example, if I read a question and one of the options is, well, I'm just going to say something that, yeah, we'll never find it, but it's going to say promote patient continues to smoke. Like that's never going to be an answer, right? So you cross it out immediately. That's not going to be realistic on your test. It's not going to be so easy. So other things that will never be an answer probably is, which is the next step in management? And they're giving you the option of pioglitazone. And you have other anti-diabetics, and one is pioglitazone. Nah, usually not the answer, because the sulfonylureas, those first-gen sulfonylureas in general, which are insulin secretagogues, are not an option nowadays, are not the right answer. Or if you have, so you get the point. So it's always useful just to read the question, just skim through the answers, and that will give you a general sense. And when you now go and look through the clinical vignette, you're like, okay, and you can just skim through it. I think the best thing to do is after you go through the question, see the question options, you skim through the vignette. Because in the past I would just read very slowly, a lot of attention into each little word, each phrase. I would sometimes underline, and when you notice like by the end of one block, your eyes are red, you're exhausted, you want to get out of there. So this is a marathon. So what you want to do is you want to just use the minimum energy necessary without compromising quality. So remember, what you want to do here is you want to answer correctly. You don't want to fix the entire patient life, right? You can read the question, but there's things you don't care about because this is a test. This is not a real patient you have in front of yourself, okay? Okay, so the answer here was sweat chloride test. And the reason I gave this diatribe is because when I read the options, I just went from inferior to superior, just going through the clinical vignette, and I immediately saw the right upper lobe bronchiectasis and surrounding fibrotic changes with pancreatic calcifications with atrophy. As soon as I read that, I went to the options again, and I thought to myself, the only thing that makes sense here is cystic fibrosis. That's the only one that would give me the pancreatic calcifications and the atrophy, and basically I think that was it. You then go to the rest of the question just to confirm that you're right, but that was the answer. What is the clinical pearl here? Patients usually present with, in cystic fibrosis, this is in adult patients. So most patients with clinical cystic fibrosis, yeah, they'll present earlier in life, but nearly 7% will be diagnosed after age 18. So how will it present in people that are a little older? Well, it will not present so bad as in a child. It means that penetration of the illness is not so bad. So it will present with chronic respiratory tract infections, unexplained upper lobe bronchiectasis, congenital bilateral absence of the vas deferens. So they're giving you clues in the clinical vignette. Remember, this patient had had several sexual partners without using a condom. They didn't tell you any moment there that he had a child, right? So they were basically telling you, yeah, this person, that could be an indirect sign, maybe. What also interesting was they told you the patient had HIV. So you're like, oh, could this be tuberculosis, right? But at the same time, they tell you his CD4 is 650. So that's not in the immunosuppression range. Remember that for you to think about immunosuppression, it's going to below 500. There's a little bit more risk, but you're getting into the AIDS stage when it's below 250. So this patient was still not immunosuppressed. So several diagnoses there ruled out. So it's like if the patient didn't have HIV, basically. Okay, so at least at that moment in time, while you're answering the question, what else happened here? We lost this thing. So give me a second. We just lost connection. We're trying to get this back on while we get this working. Let's see. It's connecting. So just gonna move this over here so we can continue here so you can see it. So cystic fibrosis, this is what we are talking about. And patients with suspected cystic fibrosis and negative or equivocal tests should undergo further testing with DNA analysis. This is the CFTR gene and or nasal potential difference measurement. So now let's go quickly to the other pearls. So this patient right here, they're asking us about a patient with trimethoprim sulfamethoxazole, and they're basically saying what side effects or what things should we be on the lookout for. So always when you have a patient with Bactrim or trimethoprim sulfamethoxazole, think of an electrolyte disorder called hyperkalemia, and this is even increased more if a patient has HIV. The risk is more elevated. Other side effects of Bactrim, a whole lot of them. Remember that Bactrim is a sulfa drug, so you can have different things. Well, sulfa allergy is one. It's not here, but yes, it's a sulfa. Stevens-Johnson syndrome, toxic epidermal necrosis, which both of these are part of the same basically thing, continuum. Exfoliative dermatitis. Then you have megaloblastic pancytopenia because of the folate deficiency generated by the trimethoprim part of the antibiotic. Trimethoprim inhibits PABA, para-aminobenzoic acid, and that will make you deficient of folate. And some renal things, hyperkalemia, impairs tubular secretion of creatinine without affecting GFR, crystalluria, and interstitial nephritis. Okay, now next question. Let's go on to a couple more. And we're gonna see this one right over here. Okay, it's difficult for me usually to answer for hospice care. And in the past, I've had a hard time answering this question correctly because usually I always think, can we do this? Can we do X, Y, and Z? And always trying to do the most for the patient. But I'm just going to show you right here in this question. Look, this patient is 62. Okay, they're not too old, but you never go off the age. You go off the quality of life, right? Or functional status. So they're showing you that the patient has has hypothyroidism and horrible COPD. Okay, you start off with that. Then you have that the patient has been admitted to the hospital several times in the past year. Then you have that the patient continues to smoke. Then you have that the patient, what else? Patient is saturating horribly. You see it here. PaO2 is horrible on 4 liters nasal cannula and maintaining, holding up a lot of trapping CO2. And you have that he's basically bedbound because here it says that somewhere it says that he is basically bedbound. Where does it say that? Let's see where it says that he spends most of his free time sitting on the couch because he is limited by dyspnea. Okay, so these are the options. What's the most appropriate step in management? So it's not steroids because this isn't an acute exacerbation, and even if it were, it's maybe time to think about hospice care. When do you do lung volume reduction? That's something I've never had a patient that has had it, but it is an answer, and it seems counterintuitive because you're like, oh, the patient has emphysema or has COPD and you're going to reduce the volume of the lung. The reason for that is because if one specific area of the lung, specifically an emphysema that has apical emphysema, you don't want to be losing ventilation in this dead space. So you can do volume reduction therapy, but this isn't the case because this patient has COPD all over in all the lungs. And also here you can see that if the patient, some contraindications are a FEV1 less than 20% and this other one, diffusing capacity for carbon monoxide less than 20% predicted. So that's going to be contraindications to lung volume reduction. Now let's go on to the next one. This patient, yeah, these are important to always review the osteoporosis or vitamin D deficiency questions because you always have all these options. You always have the bisphosphonate, you always have calcitonin, denosumab, Frax assessment tool calculation, and teriparatide. So what's the main thing in this question? This question is just telling you that this is a 75-year-old woman that although she has osteopenia range DEXA T-scores, not osteoporosis range, this is basically wanting you to trick you. This is tricking you because although you have these numbers here, the first line says she had a compression fracture. So you don't care how these numbers are. If the patient had compression fracture, that is definitory, or that's a definition, one of the definitions of osteoporosis. You shouldn't have a compression fracture or pathologic fractures. That is osteoporosis. So immediately you can cross out the Frax assessment tool because that is used if you are on the fence of is this osteoporosis or not and should I treat this patient. So we're way over this. This is not an option. But then you're left with these other options. But now you have to think about which one can I give. Usually bisphosphonate is the answer, but if you see the creatinine is pretty elevated and the GFR is 21. When the GFR is less than what? Let's see. To avoid esophagitis, oral or IV. GFR is less than 35, probably consider something else. So this wasn't the answer, and I was between denosumab and teriparatide, but I remember that denosumab wasn't excreted by the kidney, so that's why I answered that one. Let's see why teriparatide is not the answer. Teriparatide, recombinant human parathyroid hormone analog that can increase bone formation and reduce fracture risk. However, it is not recommended as a first-line drug unless osteoporosis is severe or a T-score less than or equal to 2.5 with fragility fracture, and is not well studied in patients with CKD. Okay, so that was the answer basically. And it was denosumab, and that was the main thing that we spoke about. Okay, denosumab reduces risk for fracture in postmenopausal women with osteoporosis and is appropriate for use in patients with CKD. So why wasn't it bisphosphonate? Because of the GFR. And now let's move on to the next question. This other question, basically what they're telling us here is that this patient is 27-year-old. You go through the question, you see the options. So which of the following most likely complication in this condition if untreated? So you see these things. And okay, the only one that would be dilated cardiomyopathy usually is Chagas disease when it's infection. I'm almost certain they mention it in option B. Let's see. Option B. Oh, Lyme carditis generally occurs within a... Okay, so yeah, well, Chagas would be the one that generates cardiomyopathy, dilated cardiomyopathy. So basically, when you read these options, you're not sure what you want to mark. So then you read the stem, and you read that patient lives in Connecticut, northeastern U.S. So that's Lyme disease, right? Lyme disease region in summer. Okay, all that seems like Lyme. And they also tell you here in the clinical vignette that the patient has a peripheral 7th cranial nerve palsy, which here you see it, cranial nerve testing reveals decreased corneal reflex on the left as well as upper and lower left-sided facial weakness. So the corneal reflex has to do with cranial, the sensitive afferent nerve is 5, efferent I think is 7. So they're telling you, yeah, maybe they're telling you, but all this is 7. Left 7, peripheral 7, upper and lower left-sided facial weakness. Yeah, all that is cranial nerve 7. So Lyme disease, is associated with that, and lives in a place with Lyme. So what is the usual complication, or if untreated, of these options? Arthritis, right? So that was the right answer. What's the objective here? 3 progressive stages of Lyme. One is early localized infection marked by viral-like syndrome and erythema migrans. Weeks or months later can develop early disseminated disease such as arthralgias, carditis, such as atrioventricular block, and nervous system abnormalities, such as facial nerve palsy and meningitis. And late Lyme is typically associated with intermittent or persistent arthritis in more or equal to one large joint, particularly the knee. Okay, next question. We're about to finish. This is an important one. Females with the hot flashes, perimenopausal, what is the adequate treatment? So in this case, I did underline this because always, you have to think about side effects of the medication. So they're giving you here all the options. Depending on the context of the patient, one option would be correct or another. So When you read these options, then you go to the clinical vignette and you see that she had deep vein thrombosis, meaning that estrogen is not an option. So you would cross this one out and you would also cross this one out, and it would leave you these others. Phytoestrogen supplement, I've never seen it to be the right answer in anything, so you cross it out. Dopamine reuptake inhibitor, no, never seen that in this context, so it was an SSRI. And let's just focus on this treatment of menopause. Vasomotor symptoms, mild, so just behavioral modifications. If they're moderate or severe, such as this patient, then we see if we have a contraindication to estrogens, which we did have. So that's why you would do non-hormonal therapy, or such as SSRI. But if there's no contraindication to estrogens, such as heart failure, coronary artery disease, thromboembolism, breast cancer, endometrial cancer, liver disease, so if you don't have any contraindication, you have to see if the patient has a uterus. Because if you give estrogens in an intact uterus, you risk a uterine or endometrial carcinoma. So if you have a uterus, you do estrogen plus progestin. If you do not have a uterus, you just do estrogen. Okay, this other question right here, this one I was able to get it correct, mainly crossing out things. So they were asking me about a patient this patient has arthritis. Yeah, arthritis, and they got a serum fluid analysis. So you see the options here, and then not arthritis, sorry. This patient had pleural effusion, and they got the labs. So first thing you have to think about if you want to diagnose why the effusion is this transited or exudate? So you just read the qualitative assessment, how it looks with the bare eye. It looks yellow greenish fluid. You can rule out transitate, because transitate is just going to be just a transitate, right? Which is going to occur due to increased capillary hydrostatic pressure or decreased capillary oncotic pressure. In summary, it's just going to be usually transparent. That's how a transudative will look. You will never have a transudative process looking weird. So this is an exudate. So you don't even have to stress too much about how much does it fulfill the other light criteria, at least in a question stem, right? So then you see these other options, these characteristics of the fluid. The glucose is 15. It is very reduced, so that's interesting. So something's eating up the glucose. There's a very high lactate dehydrogenase, 1,200. Cell count is elevated, not too elevated, but it is elevated with 90% lymphocytes. So it's not neutrophils, it's lymphocytes. So now let's see the options. Empyema. I crossed it out immediately because empyema would be a whole lot of neutrophils, so crossed out. Hypothyroidism. No, I was like, no, just cannot associate that with that. Pulmonary hypertension, no, because it would be a transudate most probably, so out of the picture. So then you have 2, rheumatoid arthritis and sarcoidosis. So if you go for other clues here in this vignette, this patient was from Ecuador. It's not saying that she was African American. It's not saying that she had pulmonary nodules found, lymphadenopathy, hilar lymphadenopathy, none of that in X-ray. So you can basically rule out sarcoidosis. Why is it rheumatoid arthritis? Because of all those characteristics, and also it's telling you that the patient has some findings in the, let's see, it says the patient has joint pain and swelling in her hands and wrists, plus all these other things, is rheumatoid arthritis. But we didn't know at that moment the educational objective, and this is very important. Pleural effusion is a common manifestation of rheumatoid arthritis. The effusion is typically an exudate with a low pH, very low glucose levels, and very high LDH level. So actually, a pleural effusion due to rheumatoid arthritis looks very similar to pleural effusion due to empyema. And here it explains why. So fluid in empyema appears purulent with a high cell count, more than 50,000, and neutrophilic predominance. So this patient had symptoms of joint pain and swelling, which, along with exudative rheumatoid effusion, is suggestive of rheumatoid arthritis. And that was it. And now let's go on to the last question of the day. This is a 74-year-old male, type 2 diabetes. Okay, so you see the patient has elevated risk for which of the following? So before you read all this, you just see the options. Okay, you have abdominal aortic aneurysm, all-cause mortality, chronic venous insufficiency, Parkinson, and subarachnoid bleed. Okay, so we probably can't answer this question just by this, so we have to now go and read the clinical vignette. And the main thing in this clinical vignette, I'm skimming through it. I just skimmed through it and I saw this. Blood pressure 145/75 while supine, and 122/64 while standing for 2 minutes. So that's called orthostatic hypotension. A drop in systolic of 20 millimeter mercury or a drop in diastolic of 10 millimeter mercury is called orthostatic hypotension. So now that I had that diagnosis in this patient, even though the patient mentions he has not fallen down and yeah, the patient is not having any special symptoms that I can see, he does have orthostatic hypotension, which is risky. But what's the risk here? So I was able to cross out most of these, but I was on the fence between all-cause mortality and subarachnoid bleeding. And the way I thought this is because if this patient, orthostatic hypotension increases your fall risk. If you fall, you can have increased risk for brain bleed. But I thought to myself, oh, but it would be subdural hematoma. That's what the usual bleed is when you fall down. Then I thought to myself about patients I've seen in the hospital that have had subarachnoid hemorrhage after falling. So that was sort of biasing me again a little bit. But in the end, I thought, for a test, if this is a test question, they would have chosen, if they really wanted me to answer brain bleed, they would have said subdural hematoma. So they didn't do that, so I went with all-cause mortality, and that was the right answer. And that's about it, and see you in the next one, and stay safe. Let me know any feedback, any comments, opinions. Did this work? Does this not work? How can we improve it? And see you later.